Good morning friends. In continuation of part 1 video of Vagino Resectoscopic surgery for U2bC1V1 Mullerian anomaly, we will demonstrate you how a vaginal septum incision is done. But before that, let's discuss much more about the longitudinal vaginal septum. The exact incidence of longitudinal vaginal septum is unknown, but congenital vaginal anomalies as a whole affect roughly 0.16% to 10% of the general population. Longitudinal vaginal septum specifically occurs in less than 0.03% of infants. Longitudinal vaginal septum is frequently asymptomatic. Up to 56% of cases remain undiagnosed. Remember, 56%. The actual prevalence remains challenging to pinpoint. When longitudinal vaginal septum is very commonly linked to other anatomical malformations, approximately 87 to 99% of the patients with a complete or high longitudinal vaginal septum also have a uterine or cervical anomalies such as septate uterus or diadelphys uterus. Now, whenever you when you diagnose a longitudinal vaginal septum, try to classify it depending upon the type, whether it's a partial or complete, depending upon the position, whether it's a symmetric, asymmetric, association with the cervix, whether it's merged attached to cervix or it's isolated, and lastly concomitant vaginal opening, whether it's a stenosed or hymen is persistent or not. So mostly the patients are undiagnosed, 56% are undiagnosed, and incidentally during a pelvic examination you may find a vaginal septum, or most likely when the patient comes to you during pregnancy or with labor pains, at that time also most of the patients are diagnosed with vaginal septum. Now, when you classify the vaginal septum, the most other modality of diagnosis are pelvic examination, pelvic ultrasound, 3D transvaginal ultrasound. MRI is preferred for detailed soft tissue evaluation. Now, when you diagnose a septum, you decide how to do a surgery. Usually, the other modalities of surgery are a biclamp vessel sealing system, which allows a bloodless surgery. However, vaginoscopic resectoscopic incision of longitudinal vaginal septum under continuous vision is preferred. It's a very good alternative for women with intact hymen and vaginal stenosis. Also, simultaneous intrauterine surgery, that is septum incision polypectomy, can be done. Now we proceed with our surgery for vaginal septum. However, it is a misnomer as a vaginal septum excision. We only incise. So we are doing a vaginoscopy. Remember, there are 3-4 very important points which you should keep in mind. The first is the proper distension of the uterus. Now I am marking the incision of the vaginal septum, the distal end of the vagina. This is the proximal end. On both the cavities, I go and I mark the incision, and from the proximal end to the distal part of the incision, I go on incising. Remember, distension of the vagina is very important. When you distend the vagina properly, the vaginal septum gets stretched and the surgery becomes much more easier. Remember, this is very important point. Do not attempt if the vaginal septum is not stretched properly or if the vagina is not distended properly. Always go from the center of the septum, but before that, as I showed you in the video, mark the incision from the distal end where the septum is attached to the cervix. So you are sure you are going in a single line. Always keep an eye on both the cervical opening while cutting. Third point, which is very important, always cauterize. Always cauterize the upper part and the lower part as the septum gets separated. You are incising the septum. The cauterization, coagulation is very important, because if the septum starts bleeding, it really becomes a problematic. However, you are doing under vision. As you go toward the cervix, the blood supply of the septum increases. So take care of coagulating the upper and the lower edge of the incised septum properly. So you go on cutting till you reach the cervix. Always look at both the cervical opening. if you are confused. Look, I am looking at the right cervical opening. I know I am going in a right line. I am coagulating the upper and the lower surface. I am again looking at the cervical opening. Gradually, I go on cutting till I reach the cervix. Remember, whenever you reach the cervix, look at the attachment of the vaginal septum with the cervix. If there are two cervices, remember there is always a ridge between, a cleft between the two cervices. They are seen separately. If it is a single cervix with two cervical opening, the vaginal septum is just attached in between both the cervical opening. In the next slide, at the end of this procedure, we will show you the slide how does a septate cervix look and how does two cervices look. Now I have reached the cervix, the cervical attachment. I am coagulating. That's the end of the procedure. I look at the upper part, I look at the lower part. Now this is the cervical attachment of the vaginal septum. There is no ridge, no cleft. That means it's a septate, single cervix with a septum in between. If you want to cut septum, you can go like this inside. Looking at the superior part of the inside septum, this is the inferior part, and there is no clefts in between two cervical openings. You can see the B part where there is a ridge. There's two cervices. Thank you. Thus we finish off the procedure. You can go through this slide.